here we are, back again, everyone. Hello, it's your boy, Dwight. I'm recording these intros all at once. This is hour 4 of the long live stream broadcast that I did over StreamYard on August 31st for Opioid Overdose Awareness Day on an international level. I'm trying to say that differently for every intro. This hour starts out with me and Dr. London Smith of the Jock Doc podcast, comedian, actor, and doctor, coming on to talk about opiate awareness, some of the medical components, and some interesting things about access to care in the medical field today, at least in the United States, as well as the sharing of other resources. And this is the leading into some pretty interesting stats about the overdose and the here on the International Overdose Awareness Day. As it is, we're not celebrating. I'm trying not to tell people like Happy International Overdose Day. I don't want I don't want to open with that. There's the tradition of
awareness concerning the raising awareness.
Yes, there you go. Raising awareness about awareness. I got to be careful. I mean, it's a little too meta, maybe. But what are some thoughts? What would you like to share about that? The topic of overdose and things. What are some of your things that are important to you?
I mean, it does bring to mind just a lot of the world of psychiatry in general. If you're just reach out sooner than later, if you're struggling with this stuff. And as I mentioned earlier, doctors are trained in this. So it's not like there's an ambiguity to it. Like any doctor should, if they're not going to treat you directly, then they know where to send you, so it's one of these things where it's not directly to regarding opioids, but certainly I've had family who, they'll come into some emergency situation, with regard to their, they're depressed, suicidal, whatever, and family members won't know. They'll try to manage it themselves within the family. They'll think that that's the appropriate way to do it. But once some of these things are just bigger than, interpersonal dynamics. The body, it's once again not just a mental thing, it's a physiologic thing. It's neurochemical signals and everything. So it takes sometimes more.
And that's something I just got another comment up from Melinda. Thank you for sharing this. I've worked providing clinical therapy and harm reduction support within an opioid treatment program for about 7 years. We wrap around the medical services that include highly supervised FDA medications approved to treat opioid. OUD would be opioid dependence. Underdose dependence. Oh wait, that
was the joke on that part.
The opioid underdose crisis is a whole different thing that maybe that'd be a great problem. And withdrawal, of course. That's an interesting thing where there is, I don't hear it as much, but there used to be a lot of debate, maybe still is, about the use of things like Suboxone, methadone. I mean, some people even considered that to be a relapse. You go old school. There are some people who even thought antidepressants were still drug dependence. But I don't see as many people do that. Opioid use disorder. Thank you. I should probably know that, right?
Me too.
Stumped the two of us on something we should have known. Oh, that's good. But anyway, I'd love to hear some of your thoughts about some of that, where people, because I've met people and you hear stories of people who have used Suboxone or methadone for a long, long time, and some who just use it for a short period of time. And there still is a lot of judgment around that. It's like, are you still dependent? But yet they're living a non-miserable life and they're alive. Those are two things that are kind of important.
It does remind me, for one thing, whenever I did my psych rotation, the particular doctor I worked with referred to himself as very old school. And so he's what he would describe himself as someone they send in whenever the other psychiatrists couldn't manage stuff as well. He was a fan of using meth, and I'll say he's one of those doctors who also, his walls were covered with different training certifications, whatever. And he once emphasized to us just a book on. He was just showing us what was effective, and charts of, different opioids. And he was saying like methadone is actually effective for, you can use it for pain relief. Like you can actually use it. It just won't give you the high. So you aren't thinking, oh, this is very relieving,
Yeah.
But in terms of, judging whether it's, an addiction that's, I guess a bad addiction, I can't really speak to that well. I'd say it's, once again, quality of life. And if we're going to direct services towards something, generally, I'm going to be more focused on the ones who are suffering more from it.
Right. No, it's interesting too. I had a couple, when I worked in an outpatient substance abuse program, there was a lot of people who would kind of go back and forth on that. In fact, even the state had some weird feelings about Suboxone treatment and things that, and one of the interesting things I found was that with Suboxone in particular, which I have, I guess, more experience working with people who are on Suboxone rather than methadone, but clients would tell me that they tried to abuse it. If they were, I was one person they could be honest with. They wouldn't tell their PO this. They might not tell their doctor this maybe, but they'd say, yeah, I took a little too much one day just to try it. Of course. And not everyone does this. I don't mean to say, but to test the boundaries, and they're like, it doesn't get me high. And so that helped me to check that one off the list, that I didn't have to worry about it.
Yeah.
And so that was good to know. The other thing that was interesting is I had a meeting once, a training where a Suboxone representative came. I used to work in a place where we had a lot of drug reps that would come and cater lunches to talk to the doctors, because we had a lot of prescribers.
Yeah.
And they were, especially for us, because we didn't have to go as non-prescribers. We didn't have to go to the meeting, and we got to eat the leftover sandwiches or whatever, salads or whatever they leave in the break room, all the leftover food. So, but this guy just came and just talked to us. He didn't bring anything. He actually seemed to be sharing information solely. But he mentioned that they've done some studies where people will take the Suboxone and they reduce their dose over time, and that there's a certain amount under which it is probably no longer treating any withdrawals. It is probably no longer, in other words, they could just go off it and they'd be fine.
Yeah.
But that there is an increase of anxiety around not going off, right? And that some doctors will keep the prescription going a little longer, even at a very low dose, rather than trigger that anxiety and say, hey, work with your therapist, work with your anxiety, and it's not hurting you to take this small amount, but it's not actually preventing, it by itself is probably not preventing relapse, except for it might be alleviating your anxieties. And I thought that was really interesting.
Oh, yeah, it is. So honestly, it does also bring to mind for me that working with that psychiatrist, a lot of what I learned in my brief time there was all of, we have to, of course, learn all the, at least most of the psych medications, whatever, but ultimately there's a whole underlayer of knowledge and nuances with these medications that, it's almost seems like subtle flavors, like a foodie, you're trying to pick out all the little nuances of how this affects someone's mood, or, especially if they've got multiple, for those who are struggle with addiction, but also have personality disorders, or struggle with bipolar or something like that. There can be stacks on stacks of these things, and anxiety disorders, as you were saying.
Yeah.
So
looks like, Melinda made another comment too, where the outcome from meta-analysis has led to the World Health Organization, or WHO for short. That's my editorializing, because I like to say WHO. Same group.
And question.
To clarify that abstinence-based treatment alone should not be presented as meeting a minimal standard of care for treating opioid use disorder. And if anyone saw my eyes fled over to read opiate use disorder in the line of comments, I wanted to make sure I said it right. Oh man, this is live, guys. This is live, people. Come on. So yeah, that's an interesting statement when we're talking about that. Do you have feelings about harm reduction versus abstinence based, or abstinence only, I should say? I think that's an important part, is abstinence only based treatment. the restrictive nature of that title.
Yeah. Having to draw a slight correlation. I grew up in Texas where a lot of abstinence-based approaches are practiced. And I have not seen it.
It worked really well.
Effective. Yeah. I don't see it as being that effective. Like plenty, for instance, a lot of people drink alcohol. That's a very normal thing in society, but that's still very much an addiction, a very addictive substance. It's a cancerous substance. This is a normalized thing. And at one point, I don't know which organization did, but not that long ago, I think within the last decade, they were like, women shouldn't drink because there's a chance they'll get pregnant, and that will negatively affect the baby. It was a brief thing, and there's a whole.
My sex ed, in case they already are pregnant. Okay, I was going to say there's a basic physiological misunderstanding of the method of pregnancy. If that was
a lot of my.
But in Texas, I'd believe. No, just kidding.
In Texas.
But so it's like, don't drink in case you're pregnant, no matter. That's kind of an interesting blanket statement.
Yeah, in case you just got pregnant. Yeah, which a lot of people do get pregnant while they are intoxicated. So hey, it happens.
Sure.
And so they tried applying this rule briefly of saying like, oh, women just shouldn't drink, as if that's realistic for a lot of people. A lot of people, that's very not just an addiction, but it's also just a social thing for most people. So anyway, that came to mind as a thing, like having these broad rules of saying don't do any of it. Sure, in a perfect world, that it'd be nice to not have any craving or need for anything else in your life, but that's not the world we're in. We live in a world with a lot of nuances and a lot of people who appreciate different things, and so you gotta work with the world you're in. And but I guess that does come back to the whole idea of if people are taking maybe a subclinical dose of something, is that an addiction, or is that something to manage? It's in my mind, a lot of it's just about quality of life. Are they going to need medical help with whatever they're going through currently? And if not, then they're doing better than a lot of people. And
it's an interesting way to look at it too. I know in mental health diagnosis, maladaptivity is the measure a lot of times of like, take like OCD, for example. What's the difference between having clinically presenting with OCD that needs treatment and can impair my life? Well, that's the measure. Is it impairing my life? Or am I someone who's somewhat, because we all are compulsive. Like everybody has OC, but not everybody has OCD.
Right now, with my hair. Yeah.
Right.
Very much on the same.
That's why I brought it up. I didn't, this is actually an intervention. I staged the whole thing.
I finally got my pandemic haircut, and everything's targeted at me. Like, oh, Ben, you're already addicted again.
Addicted to haircuts.
Yeah.
No, but so it's like, if I prefer my shirts hanging a certain way, and if someone moves it annoys me, that's different than if someone moves it, I have to wash all my shirts.
Yeah.
Or else I can't sleep that night or something,
three
something like
times with a certain pattern. Yeah.
Yeah, exactly. And it's like, so, there's a maladaptivity part. And I think the same goes for, at least from a diagnostic perspective, for your substance dependence or substance abuse disorder. We look at it and say, so it's interesting to say, now some people might feel that that's saying like, you can't drink just in case you get or are pregnant. Now, once again, like you said, I mean, and I guess more statistically, people often don't know they're pregnant in the first trimester, which is the most, I mean, that is a health concern, I know, is people don't necessarily stop drinking caffeine or,
I guess before that, you're also worrying about folate amounts. They can have, part of the back of their head just not have skin.
Wow.
That's I forgot the.
And that's not ideal, right? I mean, you're the doctor, but
not for a baby, no.
Right. But later
maybe
on.
You're older.
So but it isn't. It's to me that's a good example of somebody saying, we want to um, we want to solve this problem. That's a real problem. Let's go ahead and do something that somebody thinks or some group thinks it feels like it'll work, but it doesn't actually work. But we're going to attach ourselves very strongly to it because we think it should.
Yeah, it's once again, like to go back to the basic example of, text says it's broad rules of let's just apply this, and it's just not good for a population. Like for a very small population, it is a great rule, but we're dealing with a large population, a diverse population, and I also it's important to also remember that there are only so many healthcare professionals out there, so to bring I guess the guidelines are for people to not have to seek the healthcare. So maybe that's a poor example, but whenever we think of just people that need to seek treatment, the need to recognize, to see yourself as someone who needs treatment, I guess is my train of thought there.
There's also, kind of a bad history with things that are like, here's what is a medical recommendation, but only for women. I will say, the history on that's not great.
Right? Yeah. Well, and once again, the backlash was just immediate. And like they I don't remember if it was the World Health Organization. It seems like a CDC thing, but it could have been anyone. Because I wouldn't imagine the World Health, given that they have, internationally, there are many countries with more tolerance for these things. For much drinking, I guess, is all I'm trying to say there.
Yeah, gotcha. Well, and and it is that's an interesting point that there is. What's that?
In the chat, it was the World Health Organization.
Yes. Oh, there we go. It was the WHO. Oh, and it looks like Melinda is giving us some good talking points too, because it says best analogy for opiate use disorder treatment is how we view people living with diabetes and the very pragmatic treatment with medication and behavioral support. Yeah, I use that example a lot with any kind. I mentioned when Slender had first come on, we talked a little bit about how appropriate medication for especially mental health medication actually seems to correlate quite a bit with a lower risk of substance abuse, than it does. And people get concerned and they're like, well, I don't want my kid with ADHD to have to take this med. And it's like, well, not everybody has to take a med to function, but if they do, then they do. And also their risk factors for unhealthy illicit addiction goes up, right? If they're not properly medicated. And so, but you don't hear people usually say that for diabetes. They don't, oh, well, I feel like I'm weak, or I feel like I'm a drug addict because I take diabetes medication.
Yeah.
And yet if I don't take it, I'll die. And so of course I take it, but it's like, we don't give the same consideration to people who need medical treatment for psychological kind of experiences.
Yeah. And to some extent, there's obviously the stigma with it. Like, there's the question of the population, is ADHD over diagnosed, whatever, or is it like, don't remember if it was a famous quote, whatever, but like boys are just have it is one conclusion, just statistically, just because so many more males are diagnosed. But it's, if you need treatment for something, like we don't control our brains as much as we'd like. You can have these issues, and just like in diabetes, we don't control our pancreas as much as we'd like. Unfortunately, we just don't always have the control.
We don't have the shame association with it if we can't control our pancreas, right? We don't have the part of like, oh, what's wrong with your weak person? You're a bad person. Which with it,
Well, with the diabetes, I guess it is easier to say like, well, you will go blind if you don't take your meds, which isn't it's not the case with ADHD, but of course with anything with mental health versus the other types, you can see physical consequence, but that being said, like death is still there. If you don't play your cards right, either way, in either type.
It is interesting, isn't it? I mean, I had this thought just the other day. I was talking with someone about different kinds of social justice is one thing, but also like environmental concerns and like major societal problems, and how just kind of as a group, like we've agreed that certain things we just don't care about. And, it's like there's not as much awareness of the opioid epidemic, that it's getting better. People are talking more about it. Not the epidemic, but the awareness is getting a little bit better. But no, but one of the things I think is interesting is like if someone says, oh, well, plastic, everybody's like, oh, geez, here we go. We roll our eyes or something. We've been conditioned to do that. And it's like, because I gotta make it to work on time, and I gotta go do this on time, and I gotta go to the grocery store. And it's like, I just don't have time to think about it as I'm throwing things in my cart. And at the same time, it's like, yeah, it could destroy the world, but we don't talk about it. We just don't. Yeah. It's like, it's annoying to talk about. And some of the things are scary. Maybe that's why, but also it's just kind of like, we're just kind of conditioned. We don't talk about overdose because it's not going to happen to me.
Yeah. I mean, another very easy correlation there is there's currently a pandemic going on as well, that we've conditioned ourselves to some extent to play like it's not as big a deal. Hundreds of people are still dying from it every day, and that's just the deaths. And we of course have long COVID, which is scarier the more you read up on that.
It's not like not like it's either gone away or we understand it better necessarily. I mean, we understand it better than
the extent to which we understand it better. It's not looking good.
Right. It's not like we got this handled.
Yeah. Right. We're thinking, this is long COVID, which I wasn't as concerned about, in the beginning, because you're thinking just how fast people are dying from this COVID, and then of course now we see, it can be pretty bad, like, and long term, even if you don't have symptoms at first, you can have long term issues. Anyway, but so opioids, similar thing. It's there, and you're like, well, it hasn't stopped being a big problem, but. I do understand the whole tune out for a little bit, but no, we need to remember this is all important to know, and because people around you are potentially dealing with it.
Yeah. What do you have thoughts about? Schlinder asked an interesting question, which is if you were going to start a treatment program, what would you put in it? And do you have thoughts about that? I mean, most effective ways for people to be handling it
regarding opioid.
Yeah, or just any kind of addiction.
Honestly, this is it's just not so much my field. So I'd say set up with someone who knows better. Honestly, like there are people who are trained in this, and I'm not.
I was trying to pass the buck of the uncomfortable feeling of that question.
But no, I am fully willing to admit, don't go to me.
Well, and isn't that, I mean, that's the thing too, is actually going to someone, like the actual reaching out. Sometimes, once again, along with kind of ignoring something and pretending it's not going to be a problem, is we do that with ourselves too, right? I mean, that conditioning goes beyond to say like, I'm going to ignore my problem and not reach out,
I'll admit also readily that like money is an issue in this because at least in this country, people have to potentially count their pennies to know if they're going to be able to do a particular program. And sometimes I worked in Houston where they it was kind of dependent on, who you're with, what services were available, because they have it's somewhat close to Mexico. So get a lot of immigrants in there. And so it's managing all this mental health without a lot of funding for it, especially in a state like Texas where they aren't big on helping those people. So it's definitely understandable if that's happening, but even just finding out your options, even that step is worth taking. If you're in a position where you're not, comfortable or sure, just checking it out.
Yeah.
Because there are options out there.
Well, it's really true. I think that, and that's, a couple of things that come. I've known people who have mortgaged their house, even sold their house or moved to fund treatment for a loved one or for themselves. When it comes down to it, for like rehab, it can be very expensive, especially like a live-in rehab, or where you're staying there for any amount of time. yeah. So that's a tricky one,
Yeah,
and you probably deal with that. Obviously, access to care is a big thing for every branch of medical, right?
Yeah. Oh, it's pretty that like it. All the doctors that I worked with where it came up, they were like, "Oh, of course we should have universal health care." Like that's there's so many underlying issues that could be solved just with access. But now it's what comes to mind is we had a patient. I was working with a hospitalist in Houston, and we had a patient come in who she was there just for like some physical ailment. I don't remember what it was. I don't know. Kidney's broken. I don't know. And my first day, I came in to do rounds with these patients, and I asked her about how's she doing. I ran through my little list, and she said she wanted to kill herself. And the reason wasn't like she felt like she was a generally depressed person. It was because her husband had Parkinson's dementia, and in the night he would scream about like I don't know, like I think it was like police coming in and beating him up and stuff. Because Parkinson's dementia, a lot of hallucinations with that. So he's getting these visual hallucinations at night. He's screaming. She can't sleep, but they don't have money, and they're immigrants, so they're just having to basically live in this little hospital room while she's getting her treatment. And so wow. that day was pretty distinctive for me in terms of like because we aren't just speaking from the healthcare perspective, we don't let that patient go home if they express suicidal ideation. So that the next step was they were like, well, so that patient go home, and I was like, no, sorry, they need to deal with this. And which I was very apologetic because they were very ready for the patient, but they were like, no, good job, obviously, but
sure,
anyway.
but no, that is the thing, they're ready to get out and stuff, because I mean, a lot of suicidality comes from just that discomfort and misery, and who knows, even talking about it probably helped. But no, absolutely, I can understand where we've had the same.
But then the doctor, of course, at that point was like really just loudly wishing for universal health care because the patient wasn't even the one with, like, she was suicidal because this other patient who was, well, not even a patient, didn't have treatment, didn't have access. Now I top my head, and since then do not know what treatment we actually have for Parkinson's dementia with all hallucinations, but something is most likely out there. There's some type of therapy available, or at least to help her with it. So anyway, just
and those with lower access to care, and particularly, unfortunately, those that are not white, do have traditionally like there's research on like are not as likely to get a recommendation for something that if the doctor knows it's expensive, so I don't want to bring it up, kind of thing. And I understand some of that. I mean, not the racist part is a little harder to deal with, wrap your mind around, I guess. But although I understand that it exists, but from a personal perspective, the part where it's like prohibitively expensive, sometimes it's hard not to proactively take that into consideration with recommendations. If I have someone who really needs like to start coming in more often for therapy, it's hard to look at them and say, I know you can't afford it, but you need,
this is what you need.
More treatment. Yeah. It can be hard. And
it's, well, I can say, so med school, the testing is all based on, it's primarily based on, what the patient actually needs. But there are plenty of things where it's a calculation you're making. Basically, you're like, okay, well, if they can't have this, then, we have to think, okay, are there free hospitals in the area? I guess clinical rotations is where that came into play a lot more. Is they'd say, well, there's one free hospital in this area, and whatever you need, even if it's not the main thing that hospital does, we have to send you there. And it's going to be hours of waiting, but that is the option that you have since you don't have insurance or whatever. That was a fairly regular conversation to be having in the ER. Just like have to send them.
And doesn't that become like that also becomes, I think it's an interesting part of the medical social work model or the medical care for the hospital. I've had friends that are medical social workers, and that's a whole part of their thing is saying lining up aftercare and making recommendations. I'm going to go ahead and just because we're close on it, I'm going to share another charity. I don't have a website for it, but as we're talking, I remembered that I didn't get a link for this one, but you can Google Detox Volunteers of America. So if we're talking about, the Volunteers of America does do, and gosh, I haven't evaluated all of what they do in each of their programs, but they do a supervised detox program to try to keep people healthy and safe. That has no cost. That is something that is there. Now, I don't know if they have access to a lot of the doctors and medications and things. I don't know that, but I do know that they're free. And in some ways, it's almost like one of the benefits of AA. You don't have a professional there, which is sometimes probably good, and sometimes has pros and cons.
Yeah.
But it's free and available, and you can find it and access it, and so. So I'll just mention that that's out there, and that there are programs, for and for some areas, part of this is kind of, I guess, a second charity almost, but is areas they have what's called 211, which is a number that you can just dial for community resource information. A lot of places have something like that. And of course, the websites and things are better than just calling nowadays too. But for those that don't have that access. So anyway, I just throw that out there too, because like you said, it's almost like you have to become, especially in nations like ours, the one where we live, that it's all a business. It's capitalism applied to medicine, right? That you do have to get good at looking for stuff, so that you can get treatment at all.
Everyone gets a little smarter because everyone's better at researching because they can't afford to do anything else.
It is interesting. People who are proponents of universal healthcare, a lot of them are medical professionals. I think that means something. Also, the other thing that I noticed a while back was when people who I knew and would hear say, "Oh, that's terrible. It's a terrible program." All of them, Canada's program, long waiting list, England's program, long waiting, whatever, and they would critique. I noticed that the people who didn't critique it were mostly English and Canadian people.
Yeah.
People who live in a country where it's available don't have much bad to say about it.
Zero complaints from the Canadian, because I went to med school with a lot of Canadians, and that people would talk about having to mortgage their homes to get, or like they figured out their plan to get this cancer cut out, like to pay for the surgery. And these friends of mine were like, that it's so outlandish to have to think through that, because that sort of thing should of course be free. And people talk about, the long lines, whatever. But once again, you have those same issues in America, but with a big price tag. Like that's
well, exactly. It's like, is it a long waiting list when I can't pay for it and I die before I can pay for it? It's like, that's a longer waiting list because I'm, the other, and they also address things too. That's something I talked with Josh Wood, who's come on, one of the charities I plugged earlier, Improving Lives in Nottingham, England. That's one of the things they do is they address that. They have Stopgap, a charity to have people go in, especially while people are waiting for mental health care, and have social workers and community groups to talk and to kind of help people wait if they have to wait, and so they have ways of addressing it. It's not like they don't problem solve.
And there's always, or at least most places are going to have, wait lists or something, if something falls through with one patient, there's a spot to fill and whatever. Like it's scheduling. Like it's not the most complicated thing in the world. I say that as someone who rarely had to schedule people, so maybe I'm in the wrong here. But
well, it's not like it's not. There's no such thing as like we can't compare a system with problems to a system that doesn't have problems, because there's no such thing as a system that doesn't have problems.
But no, it's that does not appear that the problems in Canada do not appear to be the same as the problems here. I guess would be or maybe no. I guess another way to say it would be like I remember I worked for a neurologist, and I remember she's really good neurologist. So booked 6 months out easy, and the people paid for their healthcare there. It wasn't Canada. People paid for it, but it's just there are only so many in an area. Don't worry, she expanded her practice. She can handle more patients now.
I was worried. I was worried. No, but it actually, those specialists really are hard to get into a lot of times. Is that so? What's your main branch of practice? I mean,
I haven't specialized. That's where I'm at the point. I haven't done residency. So, which if anyone wants to know about, another poor system, there are thousands of unmatched MDs right now. There's not a doctor shortage. There is a licensed physician shortage.
Really? See, that's interesting because you hear people say doctor shortage.
Yeah, I mean, it's easier to say than licensed physicians shortage.
Well, it's always easier to say things without an understanding of what's really going on.
Yeah, no, I'm at this point, this odd point where I started, like, I was trying to do residency like right when pandemic started, and so like many high school students who went to college and then found like they didn't know enough because pandemic hit their studies. Mine was all independent, self-motivated studying during the pandemic. So I'm at an odd point in my little career here where I'm looking potentially into going into entertainment at this point, because it's been such a long wait with trying to move on in medicine.
Well, you got to find a good, solid. You got to get your head out of the clouds of this whole like a crazy doctor thing and get into a traditionally solid profession like entertainment. Yeah. I know, but what does that say about the system, right? I mean, you're trying to get into the system. Yeah,
I have I very much off the topic of opioid addiction, but I auditioned to be on this comedy show, and the same day that I did that, because I was, you work for a medical doctor, you're debating things, but the same day that I did that, I had a friend who I went to med school with, who also is a medical doctor now. He posted on LinkedIn about how he's excited because he just got a job as a life insurance salesman. And I thought, wow, this is what I'm trying to, if I do something else, let's not do, I don't want to go into sales, I guess, is ultimately what I decided that.
Right.
Even though that is to some extent what I've been programmed to do.
That's interesting,
selling
though.
A cure to their addiction.
Yeah. Man, and that's interesting, and a sad commentary on here's people, because it's not like, I mean, I know medical school is free, cheap, and easy, but no, I mean, that's a tremendous amount of investment. And it's
especially now another system that's broken. Residency as well, that's largely federally funded, and I think it was under Biden, it got its first little money boost since 1997.
Wow.
Yeah, that's a long time ago. Bad. And it's one of these things where, doctors are generally successful enough, and licensed physicians are generally successful enough that they aren't complaining a lot, and the poor unmatched MDs out here are don't have the magnified voices, and there aren't quite enough, I think, to raise a ruckus. So
that's a whole different awareness thing we should do a thing about. But no, that's really interesting, and it reminds me of this idea people have of like, oh, nobody wants to work. It's like, well, there's some barriers that maybe need to be addressed. No, that's really interesting.
The other very interesting thing is just nobody wants an unlicensed MD to work for them unless it's for a nurse qualifying job, basically. And also
makes sense.
Just for any misconceptions out there, I'm not trained to be a nurse. Couldn't do it.
Right. No, that's that's a misunderstanding, right? People look at it as a hierarchy necessarily, and it's actually a different specialty.
Yeah, completely. Yeah, I would not know how to do that job. Medical system, that I know, but
we got another, just looks like Melinda had made a comment.
Back to the topic.
Yes. The ASAM, American Society of Addiction Medicine, that's an interesting organization. I should make a note to mention that later when I'm eventually I'm sure I'm going to run a little swear some topics, although we're doing well. Haven't had to double back on topics too much yet. So the Substance Abuse and Mental Health Agency, Sam Shaw, who I mentioned earlier, agree opioid treatment programs are found to be most successful when they're accessible, when the person is ready, staff engagement using trauma-informed approach, compassionate view using harm reduction focus on progress over perfection, informed decision-making, and client-driven outcome-aware treatment planning, and use of clinical and medical evidence-based care models validated. I think I read that about as badly as I could. Sorry about that. I feel like I started and stopped in all the wrong places, but
I can.
But
to paraphrase briefly, they're saying, they use evidence-based medicine, which is the type of medicine we're supposed to be using anyway, and they inform their patients, and as I said, it's a focus on progress over perfection. You give your patients all the information. It sounds like just good clinical work. Yeah,
it's interesting though, right? Yeah, because there's cultural expectations that you look in there. Well, I'll tell you my experience. The alternative. Oh, and there's this website, and actually, this is the first. I think it was the first charity I mentioned earlier, and it's good to plug it again, which is the treatment finder mechanism on the Sam Shaw website, or substance abuse, mental health and substance abuse website, to where you can go and you can look up treatment centers for mental health or substance abuse, or both. The alternative that I've seen in some states, in fact, I believe it's still the case in the state where I practice, they actually, for state-funded programs or programs that are supported by the courts or accepted by the courts, they only allow abstinence-only based programs to receive state funding. And so you get into that, and it's kind of like, then you have, once again, the biggest problem with anything that has the word only in it is it's restrictive to goals. Whereas harm reduction is embracing the openness of, like, the person gets to decide what their goals are, which, once again, from other forms of medical treatment doesn't sound so radical, but we have a cultural expectation. And it's fine for people who do benefit or who go into a abstinence. I mean, a 12-step program would be an example of an abstinence-based program. If you're going to come in to a 12-step group and you're going to say, I still want to drink on the weekends, people are going to be like, no, that's no. That's not their agenda. That's not what they're there for. They're not there to service that. But the idea that there should be service for that, to say we need to at least evaluate if the patient's goal is realistic, by having shared experience with them, and we don't get to tell them what their medical goal is.
That's an important thing to realize. That they may not want to completely quit, and if you can get them to a point though where they aren't heavily dependent on the substance or on whatever services, if you can get them to a point where they're self-sustaining, that they're able to function in society, then that's like that is might be the most realistic goal, and that's not a bad thing for people to just be able to kind of live life.
Yes.
Well,
and it's all about an increase of health is the goal for any kind of treatment. And I'm one of those too. I always try. I don't differentiate between mental health and physical health treatment. People do all the time talk about that. It occurred to me one day where I was like, the brain is located in the body, I think. I'm not a doctor, once again. I don't have that.
Yeah, it's got to be something. Yeah.
But it's in the body, and so therefore it's physical health. It's physiological in nature, not mental versus physical. And it's like, I think when we use that terminology, sometimes that's why I like to say psychological health. Like I'd say cardiac health or something like that. At least to me, when we say is it mental or physical, we're saying are you just crazy nuts, or do you have a real problem? And it's like that's not helpful.
I'll say definitely that plenty of the doctors who this is all probably mentioned a lot, but the mental health also just drags into the physical. If we were going to it's not a huge leap to say, like I said earlier, if you're drinking a lot, you've got this alcohol addiction that directly causes cancer. Like it, wherever it goes, it's working on the blood vessels and everything. Like it's causing cancer.
Yeah.
So it's to play with the idea that
Right.
no, it's not. No, it's very much a part of it, and it's just not as, I guess it's not as easy to treat. It's more nuanced to treat because it's dealing with a person's personality rather than popping a pill.
Well, and you look at like, absolutely. Well, and looking at, losing a job, suicide, risk of suicide, things like that are absolutely, those are absolutely physical health problems as well.
Yeah.
And so, yeah, absolutely. So it's, and a lot of the practices will go to it. And then it's just like the misery. Once again, I always point that I'm a broken record with this, which is, many people, the majority of people who are suicidal don't kill themselves, but if they don't get some kind of treatment, they can be miserable, for their lives, sort of
quality
thing.
of life. That's, and fortunately in medicine today, that is emphasized throughout, our training is, quality of life is a part of your diagnostic picture and your treatments. Yeah. If they're just miserable, if a person is feeling awful, then that's something to address. Why are you feeling this way? And, if it's something that can be helped, then that's something to address. That's part of the full health picture.
Yeah, absolutely. Huh. That's very cool stuff. I mean, to be aware of when it works.
Yeah. To be aware of on the awareness day. Yes.
Yes.
I think that since I did say something fancy there, I'm going to take off on that note.
Yeah, no, that's good. Real quick, I can, anybody who's taken this time to join, tell people, where they hear you, especially with it being your, one of your big things. And
so
fun.
I provide free healthcare in a sense. I give a free health education on the Jock Doc podcast. Now, that's about 5 minutes of a given episode of the podcast. The rest of the hour or so is character-based improv comedy. So I basically read again, and it's in the title of the episode, what I'm teaching about that day. I read it like an ad copy, and I try to write it in such a way that someone who doesn't know will at least have some idea of what I'm talking about. Like someone who's not in medicine might be able to pick up on it. Though we're currently in endocrinology, so it's harder. But anyway, but it's character-based improv comedy. Dwight's been on it. And done a great job, but twice, right? Yeah. So
twice.
If nothing else, check his episodes out.
You're gonna love that.
Yeah. He had X-Men type character first time on. So
that's right. I was a Professor Xavier knockoff. Right. Yeah.
So it was it's a lot of fun, and that is one way that I avoid the morbidity of misery.
The name of it. I don't think you said the name. The Jock Doc
podcast. That's jockdocpodcast.com if you need to find a link for it easily, but it should be in whatever podcasting you use. And we are on TikTok and on Instagram, whatever, as well.
All right. Hey, thank you, Lennon. Yeah. I really appreciate you coming on.
Yeah, thanks. It was good to talk medicine.
Have a great day.
Much See ya.
Yeah, exactly. See ya.
Thank you for listening to the Court Arts Podcast Network. To listen to more Court Arts shows, visit courtamparts.com.